Okay, so I am picking up where we left off during last night's class with discussing the clinical relevance for understanding what each level of the central nervous system contributes to functions. So it's important to know what different levels of the central nervous system contribute to functioning, because it can tell us a lot about brain injuries. So body posturing and looking at body posturing is important for one piece of the puzzle when locating and determining the severity of a brain injury. So what body posturing is a response to brain injury. So abnormal posturing indicates damage to the white matter tracts that run from the brain to the body. And the way that different reflexes are controlled by different regions of the brain can, presence or absence of certain reflexes can tell a lot about a brain injury. So, for example, overactive reflexes. So tighten muscles being tightened when they should be, muscles being rigid and hard to move. So there's a couple of types of posturing, that we can look at. That is, we looked at a number of different, levels for animal studies. So we looked at Decorticate and Decerebrate animals and the different functions or lack of functions that they had. So these are two of the kind of divisions that are used when looking at this in humans. We've got kind of just Decerebrate and Decorticate classifications. So, and it's also important to note as well, just kind of comparing the animal studies with what we're going to look at briefly with humans. In cases of animals that have had different parts of their central nervous system severed, you got to keep in mind that it's not completely similar to what's seen in humans, because when these transections are done for research purposes, they're clean. It's only the fibers the connections that are severed, and animals that have had these transections have different levels of functioning compared to what is seen in humans, because these injuries in humans are happening as a result of unintentional damage, and that is of course going to be not as clean as a surgical procedure. So just keep that in mind. So with these two different postures, so we've got Decorticate posturing, we've got Decerebrate posturing. And they have some similarities and they have some differences. So let's just look at what we're looking at. So Decerebrate, let's start with Decerebrate posturing. So that's the one in the bottom here. So this, with this kind of posturing, what you will see is kind of straight arms, straight arms, down the side of the body, and also you get some internal rotation of the shoulder as well. So extension of the elbow, kind of pronation of the forearm with a kind of turning out, and also flexion of the fingers, so curled fingers, flexed wrists. So that's the upper body extremities. And then with the lower body, you get extended, the legs are extended, they're rigid, toes are pointed inward. So that's Decerebrate posturing. So Decorticate posturing, on the other hand, and the top part of this figure. So with Decorticate posturing, the lower limbs also show this extension, extension and rigidity. But what you can see with Decorticate posturing is abnormal flexion in the arms. We've got flexion in the elbows, where the limbs are pulled in tight to the chest, and the wrists are curled, hands are balled up against the chest. So we've got rigidity, flexion of the limbs, and flexion and extension reflexes. Abnormal patterns of flexion and extension of the limbs going on with these two types of postures. So let's kind of look at what's going on, contributing to the different to the posturing seen in Decerebrate and Decorticate cases. So the Decerebrate and Decorticate posturing is distinguished as being either being associated with either damage at or below the red nucleus, and Decorticate posturing is associated with damage above the red nucleus. So that's kind of the distinction between these two posturings physiologically, whether or not the damage is at or below the red nucleus. So that's kind of the dividing point for the posturing associated with Decorticate or Decerebrate. So the red nucleus is important. So the red nucleus, that is right here. So the red nucleus is responsible for flexion reflexes in the upper limbs, and it is part of a pathway called the rubrospinal path. So that's right here. So this is the rubrospinal path, and it starts with the red nucleus, and it's important for those flexion reflexes in the upper limbs. So the red nucleus through the rubrospinal tract causes flexion, grasping type reflexes in the upper limbs. So Decerebrate posturing is that posturing that occurs after damage at or below the red nucleus. So the red nucleus and the rubrospinal tract only control flexion of the muscles as far as the mid-body. So this tract, the rubrospinal tract, it terminates in the mid portion of the spinal cord. So this means that it's controlling flexion, those flexion reflexes of the upper limbs only. So the red nucleus and the rubrospinal tract only control flexion of the muscles as far as the mid-body. So in normal situations where there's not damage to the red nucleus or below, this reflex is normally inhibited by higher brain regions. So cortical regions normally inhibit this reflex. So lesions that interrupt the red nucleus and the rubrospinal pathway, they cause greater extensor tone compared to what you get for extensor tone occurring at damage after damage to higher regions. We'll get to that in a moment. So Charles Sherrington, you may have come across him in other classes. He's considered one of the founders of neuroscience. So he first described this posturing in cats. So he called it decerebrate rigidity. And he described it as increased tone. So increased muscle tone. So Sherrington, he performed live animal studies where he would, with monkeys, cats as well, I believe. So what he would do is remove the cerebral cortex kind of from this red nucleus level upwards. And he would find that, the animals, they could breathe independently, and they developed this kind of stereotypical extension rigidity of their extremities. So, and sometimes this posturing would be assumed in response to painful stimuli, for example. So Sherrington would find that these extensor postures would only occur after some painful stimulus had been applied. So he would find when he did this in cats, this extensor tone, this rigidity in all four of the cat's limbs, it would be so great that the animal could stand without support. So the rigidity would be so great that they could be kind of flipped over onto their feet, and their muscles would stay so rigid that they could stand without support. So patients with severe brainstem injuries may show similar signs, so arms and legs stiffly extended, jaw clenched, neck retracted. So these types of flexion reflexes going on unchecked by higher cortical regions. So we also have another tract that is important for the types of posturing that are observed after brain injury. Animal research, human studies as well, showing, this finger didn't come out very good. But anyway, so this other tract that's important for these kind of posturing effects seen after brain injury is called the vestibulospinal tract. And this tract plays a role in decerebrate posturing. So I apologize for this figure not showing up very well on my slide, but this is the vestibular tract right here. And this is really the only kind of part of this figure that you have to worry about. Just this one. This is just to kind of illustrate. So it comes in from the vestibular nuclei up here and extends down through the spinal cord. So you can see, the red nucleus is going to be up here. So this tract is, coming into play further down. So the vestibular spinal tract these pathways have an excitatory effect on extension muscles, while they also inhibit the flexion of motor neurons in upper and lower limbs. So the vestibulospinal tract, it excites those extensor motor neurons and inhibits the flexor motor neurons. So the vestibulospinal pathway has an excitatory effect on these extension motor neurons in the spine, and also inhibits flexor motor neurons. So the vestibulospinal tract excites motor neurons in the upper and lower limbs, whereas the red nucleus in the rubrospinal path causes flexion in the upper limbs only. So by itself, the vestibulospinal tract causes motor neurons in the spinal cord to bend the arms in. So it excites the extensor motor neurons. So at the same time, the vestibulospinal tract inhibits flexor muscles in both the upper and lower limbs, which is going to make your arms bend. So this so like with the red nucleus and the rubrospinal tract, normally these reflexes in the vestibulospinal tract of exciting extensor muscles and inhibiting flexion, this is normally inhibited by the cerebellum and the cortex, so that our limbs can move freely. So that's the thing with these reflexes, that if they are not inhibited by these higher brain regions, then we end up having either our limbs completely extended or our limbs contracted into us, right? So that's what these reflexes cause us to do. But normally we've got higher brain regions inhibiting these reflexes, so our limbs can move freely. So with decorticate posturing, actually, just a second, I'm going to flip ahead to decerebrate posturing first. So if a person shows decerebrate posturing, such as extended arms and flexed wrists, there's a couple of things going on here with these pathways. So first, we have disinhibition of the red nucleus. And disinhibition of the red nucleus and so decerebrate posturing, extended arms and flexed wrists, and this indicates disconnection between the vestibulospinal tract and the cortex, and you get this unsuppressed extensor posturing, so unsuppressed extension reflexes, where the legs are extended and the arms are extended as well. So, with decerebrate posturing, with these extended arms and flexed wrists, we have these injuries being below the red nucleus. And this is going to mean that those flexor muscles in the upper extremities is going to be abnormal, leading to this extension. So another component with decorticate posturing is problems with that vestibulospinal tract, which makes the muscles of the upper and lower extremities extend unchecked by higher brain regions. So with decerebrate posturing, you have unchecked extensor posturing because the red nucleus has likely been damaged and can no longer participate in the flexion of the arms. So they're extended at the sides. And then we've got not the vestibulospinal tract not functioning as well. Leading to this flexion in the upper limbs. Okay, so back to the decorticate posturing. So with decorticate posturing, we have flexed arms and kind of a grasping posture with curled fingers. So again, decorticate posturing associated with damage most likely above the red nucleus. And there's a couple of reasons for this posturing. So the first, lack of control of the red nucleus from cortical regions. So with decorticate posturing, the red nucleus is still intact and it's free to produce those flexion reflexes in the upper extremities. And then we also have disinhibition of the vestibulospinal tract as well with decorticate posturing, meaning that those flexion and extension in those lower limbs is there as well. So with decorticate posturing, it causes certain muscle groups in the upper body to reflexively tense up, and the cortical inputs aren't there to relax those reflexes. So decorticate posturing is associated with abnormal flexing of the arms into the chest, whereas decorticate posturing is associated with this abnormal extension of the arms. And it all has to do with whether or not the red nucleus is intact or not. If it's intact, then flexion is seen in the upper arms. If it's not intact, then this extension reflex is suppressed, and you get this contraction into the body. So so these different postures that can be seen after a brain injury can also be looked at in combination with something called the Glasgow Coma Scale. So the Glasgow Coma Scale, sometimes just abbreviated to the GCS, it is a objective scoring system that basically assesses the level of consciousness that a person is experiencing after a brain injury. So it's used to gauge, it's used to help gauge the severity of a brain injury. And the test is very simple, it's reliable, and it correlates pretty well with the outcomes following a severe brain injury. So it's a reliable and objective way to kind of record the person's initial level of consciousness. So what you have is kind of three criteria that you can that you are scored on. So criteria involving the eyes, verbal responses, and motor responses. So these motor responses are kind of what we have just been going through, right, in the previous few slides. So what will happen is you get a score on each of these criteria, and then that score is added up. So eye-opening. Does the person spontaneously open their eyes? If they do, you get a score of 4. Do they open their eyes when they're in response to a sound? You get a 3. Will they open their eyes in response to pain or pressure on the eyes? You get a 2. If there's no response in the eyes, even with stimulation, you get a 1. So then we've got a verbal category as well. Whether or not the person, if they're oriented and they know what's going on, versus being confused or not able to speak or no verbal abilities. And then we've got our motor responses. So whether or not they can obey a command that you give them, whether or not they withdraw from painful stimuli. And then we've got our decorticate and decerebrate postures. So again, whether or not they're displaying, arms being, tucked into the chest. That would be decorticate posturing, whereas if their arms are extended outward, that would be decerebrate posturing. So all of these things will get you a score, so basically the score is right here, and right here. And you add up these 3 categories, and then if the score, the lower the score, the increased severity of the injury. So if you got a 13 to a 15, that's mild. 3 to an 8, that is indicates a severe head injury, perhaps coma, perhaps need for intubation. So our decorticate posturing, that is associated with a GCS score of 3. So score of 3 on the Glasgow Coma scale, and in the motor response. And Decerebrate, that is associated with a score of 2 on the Glasgow Coma scale, and certainly indicating deeper, lower brainstem damage. So this ends up being important, because it can be an early indication of, impairments or survival chance. So, and we do know that abnormal posturing, so decorticate and decerebrate posturing, does correlate with those GCS scores, as well as neuroimaging and clinical outcomes. So the person is being initially assessed, by paramedics. That's when these postures are going to be, the GCS scores are going to be taken initially. And then once a person goes in for neuroimaging and all of that stuff, the GCS scores are, helpful for guiding, guiding the treatment of the person. So, but these abnormal posturing, so decorticate and decerebrate posturing, do correlate well with neuroimaging results and clinical outcomes. So if a person is displaying decerebrate posturing, it's likely that neuroimaging is going to show brainstem injury, and the clinical outcomes are going to be poor. So all these things do correlate together, the GCS scores, the neuroimaging, clinical outcomes, and these abnormal posturing. So decerebrate posturing is associated, like I said in the previous slide, with a GCS score of 2, and that is going to indicate damage to brainstem regions, and it's also associated with poor chance of survival. Decorticate posturing, this is associated with a GCS score of 2, and it indicates a better chance of survival, and it's particularly an indication that treatment has to be very quick to prevent further damage, because decorticate a Decorticate case can, quickly turn into a Decerebrate case if, further swelling and herniation in the brain isn't prevented. So the person could start out with, injuries that would be consistent with a Decorticate case. But then if those injuries continue to swell and put pressure on those lower regions, can develop into a Decerebrate case. So, so what is known about these reflexive postures and the levels of the brain that are responsible for them can certainly be kind of a quick and dirty but very important clinical tool, for cases of brain injury.